Hello, my name is John Bielenson, and welcome to Engage, Educate, Empower Strategies to Teach and Train Hospital at Home Providers, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. The webinar is brought to you by the Hospital at Home Users Group, and the Users Group is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and payment policies necessary to build the field and spread this hopeful, person-centered model of care. Please visit our website at hahusersgroup.org. Be sure to check out our TA Center for helpful hospital at home program resources and tools, as well as our recently refreshed Research Center, and follow us on Twitter or X. You can view any of the 32 Users Group webinars on our website, find a topic you've been thinking about or working on, and take a look. And coming up on October 16th, please save the date for Leveling Up, Investing in Hospital at Home and the Future of Healthcare. This year's virtual Hospital at Home Users Group annual meeting scheduled again for October 16. We are building an exciting program. More details on speakers, sessions, and registration will be announced in the coming weeks, so please stay tuned. This conference will bring together a wide range of leaders in the hospital at home movement and shed a spotlight on our vital community of clinicians, researchers, and supporters. Leveling Up will feature and celebrate exciting work from members like you. And to that end, we are calling for submissions of poster abstracts, award nominations, and photos and videos. Please visit our website to learn more and send in your submissions through the QR code here or on the website by July 1st. As in years past, the Hospital at Home Users Group annual meeting will be a pre-conference for the in-person American Academy of Home Care Medicine annual meeting, which will be in New Orleans on October 17th and 18th. Registration for both events will be open in June. We hope to see you virtually or in person. We want to take this moment to announce the launch of a new journal dedicated to the evolving field of hospital at home care, the Journal of Advanced Home Medicine. This journal will focus on the clinical, operational, and policy aspects of providing high-quality care at home. The journal aims to advance the field by publishing research on novel acute medical interventions and promoting the work of global societies in home-based care. For more information, please visit the website noted there, jhm.io. And calling all active hospital at home programs help us advance the field by participating in our minimum data set initiative developed by the Users Group Quality Indicators Council. The MDS is a de-identified patient-level data set that seeks to capture information on all patients enrolled in hospital home programs nationwide. The MDS aims to collect standardized data on patients and outcomes to develop benchmarks, support future development on hospital home quality indicators, support individual programs as they develop reporting and evaluation processes, inform policy and reimbursement efforts, and facilitate research to strengthen and expand hospital at home implementation. There's no cost to participate. We hope that you will join the 33 hospitals that are already involved in this essential work. Scan the QR code and fill out a short interest survey, and the Users Group team will be in touch. It's now my pleasure to introduce our moderator for today's webinar, Dr. Michael Maniaci. Dr. Maniaci is the Enterprise Physician Lead for the Advanced Care at Home program, the Medical Director of Consumer Digital Product in the Center for Digital Health, and the current Medical Director of Mayo Clinic Hospital in Florida. He currently holds the academic rank of Professor of Medicine in the Mayo Clinic College of Medicine and Science. He leads Mayo Clinic's efforts in hospital home care, known as Advanced Care at Home, and is seen as an expert on high acuity virtual care delivery throughout the United States and Europe. He has helped lead hospital at home advocacy efforts on a national scale, and his advocacy and educational efforts have been displayed on multiple media platforms. We are very pleased to have Dr. Michael Maniaci here to moderate our webinar today.
Thank you, John. Glad to be here. Glad to have some excellent speakers as well. So we're here to talk about education, engage, educate, and empower. How do we teach and train hospital at home to providers? We have an excellent panel today, and I'm going to quickly introduce our panelists. First up, we have Dr. Matthew Ehrlich. He's a practicing hospital at home physician at Brigham and Women's Hospital, where he directs clinical elective hospital at home for residents and medical students. He completed a fellowship in medical education at Harvard Medical School, and his focus is work on competency-based medical education, including development of competencies and curriculums to teach, assess, and measure progression along the competency curriculum and continuum. He is named inpatient clinical coach of a new initiative at Brigham Internal Medicine Program. Hope to hear more about that soon. Next, wonderfully to see Dr. Karen Tishner, who has more than 24 years experience developing and implementing hospital home programs, both in urban and rural settings for the UK NHS, and 5 years experience creating and growing one of the nation's first oncological specialty care programs at home at the University of Utah's Huntsman Cancer Institute. Currently, she is Vice President, Hospital at Home Operations for Maribel Health, a General Catalyst-backed company created to make the home the center of healthcare and health systems. Karen is widely recognized as a national and international expert on hospital home development, growth, optimization, has personally managed over 15,000 hospital home admissions. Her largest program is operated in London with more than 85 staff and 3,000 annual patient admissions. And last but not least, great to have here Dr. Andrew Wong, who's a consultant of family physician with the Department of Family Medicine and Continuing Care at Singapore General Hospital. He works with a multidisciplinary team to reduce unnecessary healthcare utilization through the hospital at home and transitional home care programs there in Singapore. Dr. Wong has a keen interest in medical education. He holds dual appointments as clinical assistant professor at NUS Graduate Medical School and Associate Program Director for Singapore Health Services Family Medicine Residency Program. He also regularly contributes as a tutor and examiner for the Graduate Diploma and Masters in Family Medicine organized by the National University of Singapore. He oversees the department's training of new doctors, rotations, all through hospital at home. So 3 very well-qualified panelists here. And we're just going to start off by having them each spend about 5 minutes talking about their hospital at home education program, touching upon what their providers need to know and what they teach them. Karen, I think we'll start with you first.
Okay, thank you very, very much. Next slide. So for me, being the control freak that I am, to me, it's about recruiting the right people. The SAS in the UK, which is our specialist force, say recruit the best to be the best. So even before you think about, what the provider training is, you've got to think about who you're bringing onto your program. It's not for a wallflower. It's not for, these people have to be, very confident people, comfortable with ambiguity, biased towards action, and very patient-centered, but also comfortable in their own skin and all that autonomy work that you have to do with this. So they have to be confident, engaging, and very, very strong clinically, because obviously when you're looking after a high acuity patient at home, where they're not in the bricks and mortar and a nurse isn't going to be walking past them every 5 minutes, you've got to have a very high level of clinical decision making. And then, that the core skills for those people, recruiting patients, supervising these patients that are remote, and the workforce that's dispatched out around the community, you've got to feel comfortable with how you're going to do all of that. And also the escalation of a patient, you've got to be confident in that, your decision making as to can you keep the patient at home or can you bring them in? And all of this, of course, is around collaborative team presence as well, and being that good clinical leader. So, if you look at, in fact, today, I've just finished with 40 people, a full simulation from finding a patient in the emergency room, all the way through. And so I think, when you're starting the induction for people that are coming onto this program, hospital at home, you've got to do some didactic, because they've got to understand what is hospital at home, what is the inclusion criteria, what kind of patients work for this profile. And then you've got to look at, the training around patient selection and the art of consent. You know, when you're bringing a patient onto the program, you've got to be a good salesperson. You've got to like be excited about the program and tell the patient the wonders of, you know, technology and medicine, that we can look after a very sick patient in the home. So again, you know, selecting the right person onto the program and then really teaching around how you consent that patient. And then, you know, advanced simulations. So looking at clinical scenarios, critical thinking, you know, a playground where you're actually, you know, going into, you know, a simulation lab and you're walking through what you're going to do with that patient, you know, around the virtual visits and collaborating with the team. And then, you know, you can't just drop it there. You know, medicine is about lifelong learning. So even within hospital at home, you've got to look at, you know, lessons learned, you know, mistakes, mortalities, you know, what did you do right? What did you do wrong? You know, what other things could we do even within our program? So, you know, that ongoing education and is really, really important for the performance of the team. And then look, this is about, you know, when I started the oncology program, one of the oncologists said to me, Karen, you're trying to teach me something I didn't learn at med school. Because I learned at med school to look after sick patients in hospital. I'm not going to let you look after my very sick oncology patients. I did woo him around, and he was actually our top referrer. But, you know, being based in a facility and looking after a very sick patient, you've got to learn how those skills are transferable to looking after, you know, a patient out in the community. And remember, the on-site, again, you've got everything. You've got labs you can get back in half an hour, hopefully. You can get imaging done whenever you want. The pharmacy you can get whenever you want. Whereas, you know, in the home, you've got to think, you know, ahead of the game, and you've got to look at, you know, do I need labs actually, and things like that. So very, very different managing care of a patient in the hospital compared to the home. You know, in the hospital, it's a very structured environment and you've got all these workflows. The home is very dynamic. So for some of the education, it's around all of those fantastic hospital-based skills. How can you transfer those in the home? So, you know, that is what we do with all our didactic training and all our simulation. That's all from me, Michael. Thank you.
Very good. Next, we have Matt jumping in.
Great.
Go
Thank
for
you.
it, my friend.
Thank you so much. So today I'm going to share with all of you some work I'm doing in the area of educating home hospital providers. I think one of the challenges that often arises when thinking about how we educate future hospital at home providers is that to this point, we've really been introducing practitioners to the field in kind of an ad hoc manner. So I'd like to share with you work I've been doing to develop a more structured framework through which we can approach this problem. And that's utilizing the framework of competencies. Competency-based medical education, the goal is to create alignment with a well-established med ed approach and provide a framework for curricular content and enable measurement and evaluation of the curriculum. So hopefully many of you are familiar with the ACGME competency domains. This is the definition of competency, just for the sake of a shared vocabulary. It's also something that has some applicability to an international audience because the ACGME accredits programs globally. So I've been working on a study using a modified Delphi with an expert panel in which I am using an iterative process through this Delphi to establish agreed upon core competencies. And these are the three main groups, and I'll kind of talk about the role of each of these groups as I walk you through this study. So a modified Delphi, the goal is to establish a list of competencies to be considered, which we did through a kind of brainstorming web-based survey with our expert panel, which was a multidisciplinary panel that includes clinicians, nurses, pharmacists, as well as actually people with direct experience as patients. So they submitted a total of 267 items back to the expert panel. The steering committee, which consists of myself and a few other members of the MGB Home Hospital Program, edited that down into 83 items within 31 clusters within those domains, within those ACGME domains. A few examples of the clusters, if you could go to the next slide. So these are some within practice-based learning, systems-based practice, patient care procedural skills, medical knowledge, interpersonal and communication skills, professionalism. So these clusters were sort of the main themes identified. We have a review committee rather, that consists of experts in competencies and medical education who provided notes and feedback, which we have then submitted to our panel. And we've gone through the first round of voting, in which the study panel has voted on 64 items. Next slide, please. And if you click through this, you can see the results of the votes. So, sorry, if you could go back one slide. So we have consensus on 40 items. That's sort of a preliminary consensus, 21 that need to be revised, and we've eliminated 3. This is going to be an iterative process in which we'll also be eliminating redundant items. And the hope is to end up with somewhere in the range of 20 to 40 final items that are competencies that can serve as the backbone for future competency-based medical education for home hospital curricula. So if you'll go next slide, that's kind of where this next phase, which we would love input from the hospital at home community, and that's public commentary. This QR code will take anyone who follows it to a survey that's open to the public that will allow you to comment, see all of the items that are under consideration for competencies, and provide feedback. And we would really value that public feedback as we're working on honing this list of items, because my hope is that this serves as a broadly applicable set of competencies that can be used for the whole home hospital community. So I think we can skip through these next slides and just land on that final one. Again, one more. So anyone can reach me for more information about this. And again, please follow this QR code.
Wonderful. Thank you, Matt. Andrew, you get to wrap this part up for our next section. Go right ahead.
Thank you so much for the kind introduction, Michael. And thanks the Hospital at Home user group for sharing. Good morning, everyone. I'm Andrew. I'm a family medicine consultant from Singapore General Hospital. So it brings me great pleasure to share with you my department's effort to train doctors in hospital at home care. So in a nutshell, in my 30-bedded hospital at home unit in Singapore itself, regularly across every 6 months, we have new doctors rotating through our department, and these are called medical officers. And most of them had never worked in a hospital at home environment before. Thus, it is with our keenest hope that after this 6 months with our training, that these medical officers will acquire knowledge, show understanding, and apply relevant skills to deliver equitable, safe, and effective care to all patients of various disciplines in Singapore General Hospital itself. So our short learning objectives are really for the medical officers to be familiar with functional knowledge from the very start of patient's journey in recruitment to being grounded in the daily work rounds to discharge in hospital at home, and for them to acquire soft skills of being patient-centered, as well as to be able to work with the multidisciplinary team itself. So we designed actually a series of training activities, and those of you who are well acquainted with education itself, we adopted the Miller's Pyramid to go through 3 tiers of acquiring knowledge, shows understanding, and apply relevant skills in in helping them to be more well acquainted, and practice to be an active practitioner in hospital at home skills. And this would include things like having pre-reading materials, lectures, presentations, and preceptorship. So this is actually a very loaded series of presentation, of which I'll curtail it to just 3 special mentions from our medical officers of what really helped them. First of all, procedural training. So traditionally, most of our locally trained doctors would have not been formally trained in medical school for nursing procedures such as setting lines and infusions, injections, or even performing point of care tests itself. So 6 monthly, we have our nursing experts to come in to help to train our doctors to perform these competencies itself, to learn about these and to actually perfect the skills. And that would include setting up lines and drips, securing these lines itself, performing point of care, like for example, INR testing, and also to be trained in delivering injections such as subcutaneous or even intramuscular injections itself. So this training, a lot of our medical officers found it very useful, because a lot of times they are put in a situation in which they are the only healthcare professional to do the medical assessment at home, as well as to help to deliver treatment itself. So this is indeed very helpful for them. So case presentations are actually normal fare for our day-to-day practice itself. So this case presentation actually helps our medical officers to reflect on what is equitable to our patients during daily huddles itself. At the same time, this case presentation also help the trainers know what they know and what they do not know. And honestly speaking, in these 3 domains, equitability, patient safety, effectiveness, we are able to be more assured or even more committed to increasing our trainees' knowledge in these fields for each individual patient itself. So take, for example, in terms of patient safety itself, we actually get our medical officers do their presentation to actually reflect upon patients who have, from the hospital and home environment, returned back to the physical hospital, to reflect on what are the potential safety concerns and how could they do things better as they return these patients in a very expedient manner itself. Last but not least, in the peer review learning itself, we deep dive into what's really good as well as efficacious care in terms of novel treatment options for patients with complex needs itself. So last but not least, we made it a personal commitment amongst the trainers not to launch them into the deep ocean upon the first few weeks of training itself. So our approach is really a graded approach in which we will slowly preceptor them and grade them from direct supervision of their work itself to indirect, and to some of them even independent work. And that really greatly enhanced the confidence of our medical officers. As an educator, my personal reflection is that actually learning is a continuous cycle. It's an iterative cycle, and we need to constantly improve these processes. The processes between the working environment, the interaction between trainers and learners, as well as the interaction between trainers and the working environment and the learners and the working environment itself. And I feel the learning process and experience can only get better as we tighten our gears and all our engines to benefit our patients. So with that, I will end my presentation. Here's an invitation to learn more about the place which I practice, which is Singapore General Hospital at Home program, or you can feel free to contact me should you have any questions. Thank you so much.
Wonderful. Great overview, Andrew. And Karen and Matt, last to come back and appear before us. So I have a couple questions that I have that I'm going to throw out to the group here to start us off, and then we'll jump in the Q&A from everybody else. But Karen, I think we'll start with you. Really, what core competencies must be reimagined for clinicians practicing in hospital-to-home model? What do you think?
Yeah, I mean, I think reimagining the core competencies for hospital at home, it involves a significant shift, I think, of care delivered and coordinated and experienced. So therefore, it necessitates an adaptation of your core skills. and clinical competencies. So for me, there are many, but I would say critical thinking is one that I think you definitely have to evolve and grow, because that's essential when you're looking after high acuity patients. If you've got 100 patients on your program and many of them are needing 3-4 visits a day, if the people leading and managing clinically those patients aren't confident in their ability, I think you're on a sticky wicket, really. So I think really having that critical thinking, and then again, the clinical decision making. So can you manage the patient at home? When you've got the patient at home, if they're deteriorating, you still have to look at the core competency. You have to have the skill set to know and understand your team, believe in the team, believe whether they can, manage that very sick patient or not. And then understanding, diagnostics, because we know in the hospital, they'll stick a needle in you every 5 minutes if they can, so it's like, what do you really need? Because we know that, your assessment is 98% of looking at the patient, and then your diagnostics is just adding to what you actually think is happening. So for me, some of the learning around, when do you need, to escalate them back to the hospital for something that you want to do, or how can you manage that at home? So I think in all the scenarios and things that you do, expanding that critical thinking and clinical decision making is really, really important. And then something, even today when we were doing the simulations, for somebody who's never done a virtual visit with a patient, and you've got like a paramedic or a nurse in the home, it's very different to standing by the bedside. So you have to learn a whole new skill set, because you're like, hello, Mrs. Jones, how are you? Instead of like talking to the other professional, you're there for the patient. And I mean, the patients love a virtual visit, because, they think it's a real treasure having, a doctor to call them in their own home. So I think even learning skills around, using the remote patient monitoring, using the virtual visits, and how you do that is really, really important. And then, up there is communication skills. If you can't talk to, if you can't talk to a patient, if you can't talk to your nurses, we know not everybody, anesthesiologists or anesthesiologists, because they can't talk to anybody. I'm only joking, I don't know. But you've got to choose people on your team that are, one, they're great team players. They are confident in their skill ability and in the abilities of the team, but actually they're really strong, clear people. They're good at communicating with the patients, with the relatives, and they're also very good at conveying that to the patient and to nurses. So for me, that's kind of the main competencies that I would say are core skills.
Excellent. Thank you, Karen. That was a good run over. And following up a little bit on that question, Matt, how do traditional inpatient skills translate or fail to decentralized tech-enabled care, and what needs to be prioritized with new proficiencies?
Sure. So I think there's a few answers to this question. I think the first maybe sub-question is, what skills do we need to be able to transfer from the inpatient setting? And I would argue that they all need to be able to transfer. There's not really anything done in the practice in the inpatient setting that I think you don't need in the home hospital environment. I think in the same way that in a global health setting where access to advanced diagnostic tools or frequent diagnostic testing may be more difficult than it is in a brick and mortar academic medical center in a major urban area here in the US. I think that it underscores the importance of basic clinical skills such as physical exam, clinical and diagnostic reasoning. And I think that also applies to the home hospital environment in the same way we often think about that in a global health setting. I think specifically there are many kind of knowledge, skills, attitudes, some of which have been highlighted in our presentations thus far. If you guys had an opportunity to follow the QR code to that survey that I linked, I think many of the clusters identified some of the things that our panel has prioritized. I can just mention a few. I think providers really need to be highly knowledgeable about and skilled with the technological tools that their system is utilizing. That may vary from system to system, but I think broadly speaking, that's really essential. I think interdisciplinary collaboration is critical and different in the home hospital environment in a way. Yeah, it's different from the inpatient setting. You need to work with your interdisciplinary team for things like assessing safety in the home, performing virtual physical exams, creating a safe therapeutic environment. All of those things are profoundly different in the home hospital environment and are skills that I think every provider has developed over time, but are things that we need to become more intentional about educating. And the other thing is, how do we educate patients, family members, care providers, and how to be active participants in the care plan in a way that is obviously, we all know from experience, different from the brick and mortar environment. So those are a few, but I think the list is very long, and I think that's a lot of the work that we need to be doing right now.
Sure, no, great points, man. I think that's key, and that education. And where can it start? Does it, when it starts in home hospital, it's usually too late. And starting that in the outpatient world, the primary care world, preparing them for this, and then engaging. I think you're absolutely right. We don't want to increase burden on caregivers, but if they're in the physical hospital, that patient's going home in 4 days. Burden's there, whether they like it or not. So preparing them for that and actually getting them better prepared is key. But that's part of the educational process. And you're right. I won't even get into the tech part. I can't get Zoom to work half the time correctly, much less run a home hospital with the tech and how to troubleshoot when things go wrong. Going back to what Karen said, troubleshooting is key, and improvising when the tablet doesn't work and you need that exam. How are you going to do it? It's all part of it. So quite interesting. Next question, Andrew, we'll go with you on this one. Is we've talked about some education, but how do you structure training pathways to prepare these future providers across all levels of experience? What does that look like? What do you tell a medical school or residency program of structure?
Okay, thanks for the question, Michael. I think that's a very difficult question to answer, and I can only share with you from the Singapore General Hospital's experience of what may help and what may or may not help itself. So generally, I feel there's no running away from needs analysis as a start. So usually what happens in my setting is that for our inductees, no matter at what level of experience they come from, be it freshly minted medical officers to even our specialist attached colleagues itself, we do ask them, what do you want to achieve in this half a year? Okay, and also on the outset, we had devised a short assessment tool in a form of multiple choice questions, which are targeted to actually sieve out what they know about certain elements of our program itself, particularly in recruitment, okay, onboarding, as well as daily assessment itself. So that in itself helps us to kind of tweak our already fixed curriculum to mold it into focusing on what they would need to or even desire to grow more in itself. So through like what I mentioned in my presentation, sometimes articulating the patient's care needs during presentations and even showing their skills through hospital at home daily work rounds itself actually does give the educators a very good feedback on where they have gained in that training itself. So last but not least, but I feel one of the core important tenets would be to have the feedback at the end of the entire training session. And that feedback actually is very precious. It gives insight to educators of what is being done well, not done well. It also gives insight to the educators on the final outcome on our patients under the care of our new medical officers itself. So how has this been things been before or after the training itself? Do we see patients having a greater patient satisfaction scores? Do we see patients being more comfortable with the with this new care provider itself, and even collaboration within our multidisciplinary team itself? Do we see actually someone who is actually more well integrated into our healthcare delivery ecosystem in hospital and home? Yeah, so this is an experience which I think could be very different from different providers, different training programs, but something which I felt that structure and fluidity probably would need to balance a little bit. Yeah, thank you.
Sure, thank you, Andrew. That was great. Karen, touch about this subject and really looking at you who've trained many different levels of providers in many different areas, not just physicians, but nurses and other staff. What educational formats, you mentioned simulation, but others in that one as well, that are most effective for onboarding? And have you seen a difference between providers and what you use when it comes to the effective formats? Does something work more for the nurses and others for the physicians and others for technical staff? What have you seen with these training and the formats that are out there that you've used?
Yeah, I mean, I think you have to be very thoughtful about your educational framework, because, you want to create clinical confidence and technology fluency, but also while building team. Because for me, hospital at home has to be about team, because, everybody's, if one duck is out of line, things aren't going to flow. So for me, I think it's got to be some didactic, because they've just got to understand, as I said, things that are purely about hospital at home, because in hospital, if you're admitting a patient, there's no inclusion, exclusion. If they need a bed, they need a bed, and you're not going to exclude them because they live 20 miles away. So it's very, very different, looking at this kind of thing. So I think you do need some didactic classroom work. But for me, it's also about, mock home environments, scenarios. So you're running past like escalations, you're talking that through, you're maybe running scenarios around that, not necessarily simulation based, but actually conversational based, to say, okay, we know we've got an escalation plan, run through some case scenarios and say, okay, Mrs. Jones got XYZ, would you keep her at home or would you bring her in? And then, looking at crisis management. So, when is it right to bring a patient back in? And looking at that, but also understanding in all of that, the team. So, do any doctors know what a virtual nurse does? Do they know their skill set? So actually, why not do ride-alongs? Why not have part of your induction be that every provider that's going into your program has done a home visit with somebody, or has sat in the virtual care center and listened to the knowledge base of that virtual nurse that is looking after. So I think all of those things are very, very important. And then, being proficient in technology is a big deal. So you've got to learn and know what's out there and know how to use it to your best advantage. So I think a mixture of didactic sims, but an actual practical, going out and spending time and shadowing people on your team, because one, that will build confidence, and you'll know, oh, Karen's on today, I went out with her, she's a brilliant nurse or she's a terrible nurse. So actually, if she tells me something, I'll either believe it, because you have to build confidence in your team. So, and I think some of that is spending time, because when you look at a dispersed workforce where there is no real team spirit, trying to do something in your training that connects you with the team that is involved in the care, I think is very, very important. So, around like team communication, how do you communicate with somebody? You don't want a snappy text. You want to be kind, because we're all doing our best. So it's even, how do you deal with somebody that's frustrating you and you want to pull your hair out, because we know that once it's in a text, it's out there, it's, it's said and done. So I think even communication skills and things like that are really important.
Excellent. No, I agree completely. And team is a bigger word when you have partners, vendors, and people outside your organization. It's a really, you have to be good at communications, have a clear pathway. couple minutes just on this question. I'll hit Matt with it first and then maybe ask Andrew a follow-up, and then we'll jump to our few questions online here. Diagnostics. Matt, you said you have to learn all the skills in the hospital you have to apply to home hospital, but how do you teach that virtual clinical exam when somebody's not there in front of you? What are those exam skills you have to pass on to your learners when you're teaching in the living room and not the ward?
Sure. So at the risk of sounding like I'm kind of pitching my own work too much, I think at the foundation of any educational approach is agreeing upon the standards of what knowledge, skills, attitudes, and behaviors we really think are central for the practice. I think Karen kind of touched on it already. As far as specific tools utilized, I think because so much of our learning before any of us move into hospital at home care is done in the brick and mortar environment. We're so accustomed to that environment that there's really no substitute for getting us out of that comfort zone. And so some of that's going to have to start with just experiential things like simulations, cases. It's going to have to be also a lot of observation of more experienced providers in the home hospital setting, because I think many of the nuances that allow you to translate the skills from the brick and mortar into home hospital there's no reading that's going to totally prepare you for that. You have to have kind of hands-on experiential opportunities through simulation, through cases. I also think interdisciplinary exercises, getting back to this idea that as much as teamwork is critical in any medical practice setting, I think it's at another level of importance in the home hospital setting. So really learning how to utilize the resources that are your team through interdisciplinary exercises. And then I think on the back end, debriefing through things like didactic sessions, M&Ms, are a really important way to make sure that we're going through this iterative process of what is ultimately an evolving field of knowledge, where so much of the knowledge base is still kind of on infirm ground, that we're using that as an opportunity to learn about mistakes that have been made and constantly be improving our practice through that sort of iterative approach.
It's great, Matt. Yeah, I would double down on being able to read the room. That's something that people, it's key to especially virtual visits and in-home visits, where we often don't do it well in the hospital. We see many learners walk in a room with a plan and they just go right into the plan, and they're not noticing that the patient's breathing 80 times a minute and the IV's dripping on the floor and the mom's there crying, and it's like, we got to talk. And they're talking about discharge. You're like, no, let's read the room, people. Something else going on. And that's core with home hospital, especially in a family environment. So you're absolutely right. Andrew, any other special tips on, doing without being able to touch when it comes to physical exam or any other skills in the home that you've seen with your program?
Just to share, so I think what's important for the hospital at home practitioner is to pick up a sick patient, as well as to pick up patients and or caregivers who are in distress. They're in trouble, they can't cope. Yep. And sometimes they don't articulate it well. So to be able to do that itself, I'm just speaking of Singapore General Hospital's experience. I believe it would apply to many practitioners' experience too, is that we frequently utilize telecollaboration, that we have both a mixture of an on-site practitioner to do the assessment, augmented with videos as well as pictures, as well as a off-site video consulting doctor. And if need be, the threshold of having a on-site, converting to an on-site medical assessment is very low for these sick patients itself. So the long and short of it is, I feel that to deliver equitable care, I think there is no running away from doing what we usually do in the brick and mortar hospital ward environment to the patients into the patient's house itself. What I felt could also be helpful is to really look at to have a constant practitioner to care for the patient, so that over a longitudinal stretch of time, let's say in a couple of days, you really would be more attuned to pick up changes. Yeah, changes in the clinical state, changes in the distress level, and that will help to influence clinical decision making better. Yeah. Thank you.
Thanks, Andrew. We're going to jump online to some of the questions here and question and answer. I'm just going to pick one and then shoot it to one of you and just keep going through. Karen, I think we'll start with you. You've answered a couple online. Thank you for that. And I think this is a good one for you, which is what sort of external partnerships are necessary for implementing and running a successful program? And what training is involved with that when it's somebody outside your organization that isn't part of your residency or something else?
Yeah, I mean, I think it depends on, you know, if it's totally new to you and you've never done hospital at home, I think having a partner that knows how to do it is very, very important, because they can help you. I mean, for me, there's no two programs that are standardized and are exactly the same, because you have to build it for the health system. So I think, you know, having experts alongside you, designing your program, building your program, and then on the back end of that, training your team, and then the at the elbow support from those experts while you're launching, I think is really, really important. You know, it's not to say, you know, obviously I've built multiple programs and I did it on my own, but I had experience, you know, I had 20 plus years experience. So I think particularly in a very complex system like the USA, social health's easy because there are no rules. You know, the patient doesn't have to meet this, or you're not worrying who's going to pay for that. So, but you know, in a very complicated fee-for-service world, I think it's you know, where there's rules, and even every state has regulatory rules. So I think, you know, having and looking at platforms and remote patient monitoring and all of that, I think, you know, it's a bit of a minefield, and unless you know how to navigate that, and you've got people and experts that can help you, whatever that means, even if it means just a one-off call with experts, or whether it means that these people are going to hold your hand or actually implement the program for you, and, you know, outsource your nurses, your virtual nurses, or outsource your physicians. You know, you have to just I think there's plenty out there of helping hands, but I think trying to build it on your own, I think, is a very daunting experience if you've never done it and you have no good connections to help you.
Very good. Excellent. Excellent. Andrew, someone asks, hey, you're teaching home hospital care, but is there an overlap with primary home care, post-acute home care, mobile integration, transitional care? You practice a lot of this, so what do you think?
Okay, my short answer to this is yes, there's a lot of overlap. In fact, in one of our induction multiple choice questions, this is exactly what we ask. Yeah, so post brick and mortar care, what are the differences between these services itself? And I think it's very important to identify that hospital at home care is essentially an acute level care, which requires daily monitoring and intervention, as compared to transitional care, which is within the first, time limited. For SGH, Singapore General Hospital, it's 1 month. And it is essentially with slightly different aims. Yeah, one is acute, and we are treating, okay? In a way, to a certain extent, it may be more reactive, okay? Versus something which is more preventive itself. Yep. So definitely there is overlap. In terms of curriculum-wise, we are still in the process of devising a curriculum for transitional home care itself. But the main tenets of home care doesn't differ too much itself. It's just the depth of comprehensiveness, as well as stakeholder engagement, which in a transitional care program, we probably have more luxury of time to bring our partners together. Yep. Over.
Thanks, Andrew. Matt, I like this question because I know what my answer is. I want to see This goes, not only teaching education, physical exam, and hospital at home, but change management. And this question is, how do we engage physicians who may not have much skin in the game or refuse to see consults or have a very low threshold? So how do we teach the ones that refuse to be taught, that aren't in the education game, but our own colleagues, that we now have to engage in this new type of decentralized care?
Well, tough question. I think, I mean, ultimately, any new care model is always going to have some resistance, and so I think some of it is just patience and persistence on our part. I mean, I have found, I've worked with like ED colleagues, presenting to them on home hospital, sort of sharing with them information about the model. Spend a lot of time with like the orienting emergency medicine residents during their orientation. I'll give a presentation. So I think that's certainly one opportunity, is getting to them early and sharing with like the sort of next generation of providers, both how the model works, what the evidence for it is, and I think oftentimes you'll find more openness to that. Same with internal medicine residents. So I think probably the best answer to a challenging question is trying to reach them early and often, and really emphasizing the evidence both about quality as well as patient satisfaction.
Great, great. I'm going to hit two birds with one stone and really talk about the format of training nowadays. What are people seeing? Is this formal in medical school and residency, or is this more less formal and just rotations and things? How about all three of you, just 1 second apiece on what you see at the different programs you've been at? Is it more formal, less formal, or a little bit of both, depending on what's evolving over time? We'll start with Andrew, then go to Karen, and then go to Matt.
Thank you for the question. So, as you know, actually medical school education as well as specialist training programs are actually essentially very packed already. So with a lot of postings from the core relating to their core competencies, in fact, hospital at home at times is given a back seat. So I would say a lot of times it's really informal training. Yeah, because it hasn't yet to be structured in the curriculum, at least from my experience. But I think this is an opportunity in disguise, because as the programs develop, as the number of beds scale up itself, and our medical students and our colleagues from other specialties become eventual partners itself, I think there's a value proposition in having a formal program training for them. Yeah.
Sure. Karen?
Yeah, I mean, I would just say, within hospital at home, it really needs to be its own specialty. We're not there with academic institutes. Certainly I worked with King's College London, and when they did it, the nurse practitioner masters, they did a module for hospital at home. So our nurses, therapists, pharmacists all went through that. But I think even with doctors, we've got to start thinking this is the way forward, and this is the future of medicine. So how do we get institutes and doctors interested in doing this? So certainly one of my London colleagues, she rotated all her junior staff through it, so they had to come out for 6 weeks. Then she did fellowships where they came for a year and spent time in it. So I think when there's lack of formal with institutes, we've still got to try and say, we had student nurses in our programs, we had student paramedics, we had, student doctors. I think you've got to wake the world up, because not everybody's heard of hospital at home. So I think until the academic institutes wake up and start to create programs for it, I think we've got to just bring people in and get people excited about it.
Wonderful. Matt?
Yeah, so in my program, I'm the director of an elective for both residents, internal medicine house staff, as well as medical students. I think with that said, part of what I saw through this experience is that where you go from just having an elective or just having an elective does not necessarily mean a formal curriculum, right? Like you can bring people in create an experience, but much of that to this point has been done kind of in this ad hoc manner, just trying to get people the exposure. And I think part of my goal with the work that I'm doing is to try to formalize that as much as possible by kind of creating standards and then from there building out a whole kind of library of curricula.
That's wonderful. I think that touches a bit upon the last question that's left on the board that we haven't answered, which is the extent of current curriculum and development and what we're pushing forward to medical students and residencies who aren't interested yet. And that's a big question is, okay, the institutions with home hospital, obviously we're going to teach virtual care, but what about everybody else that isn't in that field yet? Maybe they're in other parts of virtual care, so it does blend across different lines and tiers, as Andrew said. Gotta know it all. But any last advice in the last minute and a half here for anybody who's not teaching this yet is that, hey, we better get on it because it's part of our future, or is it something else?
I guess one piece of advice I would have is that I think this is a very collaborative field at this point. And so folks who don't have exposure in their own institution should find emails and reach out to people and try to engage in that way, because I have found in my own experience that people are really interested in growing this field. So meeting people and finding ways to gain exposure just through connections, I think is a great first step for folks who are looking for the exposure but may not have it in their own institution.
That's great, Matt. Any last words, Andrew or Karen? I think we're right at the end here at time. So I want to thank you all for being part of this panel. I know time flew by. This is an important thing, difficult, but you guys are the experts, and we'll be available even after this webinar for questions and follow up if anybody has any.
Great, thank you. I just want to say thank you again to our wonderful panelists and moderators for such a rich and informative discussion. Before we close out the webinar, we just had a few final reminders. October 16th, please save the date for our 7th annual meeting and stay tuned for more information about the program. Registration will open in June. You can visit our website using that QR code to learn more about the event and how to get involved. We are currently calling for submissions of poster, abstracts, program and/or Clinician of the Year award nominations, and photos and videos. So check that out. And here's a call to help us move the field of hospital home forward. If you are part of an active HA program, we strongly encourage you to join your users group colleagues in participating in the MDS initiative. Scan the QR code to fill out a brief interest form, and we will be in touch. And visit jahm.io to learn more about the Journal of Advanced Home Medicine, an open access peer-reviewed journal with a focus on hospital at home. And this webinar is one of a long-running series presented by the users group. The full library of webinars covering a range of topics can be found on our website, hahusersgroup.org. And for more information can be found at our website. So take a look at our Technical Assistance Center, which offers a host of helpful resources on key hospital home topics. Our current featured resource is an introduction to age-friendly care in hospital at home. And finally, thank you to the American Academy of Home Care Medicine and the John A. Harper Foundation for their support of the Hospital Home Users Group. Thank you again to our panelists and moderators and to all of our attendees, and have a great evening.